The next case is a young woman of 30 years old. In February 2013, she presented abdominal pain with diarrhea and with blood and weight loss and dysphagia. We performed a coloscopy and found ulcerations of the terminal ileon, and on histology we could diagnose a Crohn's disease. The gastroscopy showed an extrinsic compression at 24 centimeters of the dental arch. And the problem is there is a difference between EUS and MRI. EUS shows an hypoechoic mass of 30 millimeters with no enhancement after Sonoview injection. And the first diagnosis we could think was esophageal cyst. But MRI and the CT scan showed a solid mass. So the patient is scheduled for therapeutic endoscopy if it's an esophageal cyst. Here on CT scan you can look at the mass in the mediastinum. So let's move on the endoscopic room.
We just started the examination with a linear and EUS scope. It's an EG 3870 UTK scope, and we are exactly at 25 centimeters from the incisors, and you can already see the lesion in grayscale mode. So we started with the grayscale mode. We can adjust a little bit, we can play a little bit with the settings. So if you want to adjust the frequency, then we can take the tissue harmonic imaging out, and now we have the frequency set up at 10 megahertz. If you want to look, let's say, a little bit deeper with a better penetration, then we can change the reference frequency. So you can appreciate very well that the lesion is cystic. It's a large cystic lesion, and you can also delineate very well the walls of the lesion. What you can actually see is that the posterior wall has a layered structure. So what we think it is, it might be a duplication cyst. We've discussed that before. So what you see is several layers in the posterior wall. I will try to show it. If you look at the pointer here, then you see several layers. So it might be the normal esophageal wall there. So we don't think it's solid at all. It looks really liquid. It's anechoic. So now we have increased the mechanical index, and we have 0.2. And if you look on the left image, so for the low mechanical index, the contrast image, we have 0.2, and for the grayscale image is 0.03. So we don't want to destroy any bubbles. So now you see it already in the artery. But there's nothing inside. So let's try to increase a bit the mechanical index. So you can see it inside the artery, but there's nothing inside the mass. So we think it's completely cystic.
So the idea here will be to try to make a fenestration of the lesion and to make it on the, if it's an esophageal duplication. So we are here at 25 centimeters from the teeth. If we want to do a fenestration, I will make the puncture from the upper part of the pseudocyst. We are in pure cut. And I will use for this puncture, of course, we need to have a fluoroscopic guidance. I think that it's always a good safety to have this fluoroscopic guidance. Okay, you see that it's always a little bit more comfortable when you have the scope in a straight position like that. Of course, we will make sure that we have not vessels in between. I can inflate a little bit the balloon, just in case. A little bit more magnification is never a problem. So when you use the cystotome, I always prefer to use it in pure cut, especially when you dilate the entrance. Okay, you see the tip of the needle. And now we are inside. But it's not floating, you see, Mark? It looks to be a kind of thing which is semi-solid. So maybe we will make an aspiration to see if we have liquid inside. You see? You see that the needle is, the catheter is not moving like it would move in a...
It's okay.
So probably the radiologist might have been right. But so normally you see that
Is
when
it
you are
mucin
entering
or
a
something
pseudocyst
thick,
or a cyst of any
thick
kind,
mucin or something like that?
you see when I push a little bit the catheter like that, I should move, which I don't do, but this is a solid lesion. That's very interesting because everything was for liquid. So I'm using the 22-1 Cook needle for cytology. So it would be a very big gist. But the strange thing is, you see that, well, I don't know what you think, but we have the impression that it's developing inside the submucosa then, because we still have...
That there is a normal structure of the layers. Yeah.
So it might be, so it's a little bit big to be resected like a poem by submucosal dissection. But you know that there is more and more possibilities now to resect this lesion when they are not too big, using the submucosal dissection in the same way that we do for... Okay, you can... The same way as we do for the achalasia treatment. Of course, this one would be extremely big to be removed through the orifice in the mucosa. So we are using suction during the puncture. I know that Anan is here and he never used suction, I think. But I think that this is the rule here in Marseille to use suction during the puncture. This is what we do too. And we see very well that it's a solid mass, not very hard. Maybe among the moderator or the audience, somebody has an idea about the diagnosis?
Maybe it's thick mucin or something like that.
Solid,
Do you
it could be
think
a
so?
myoma.
Yeah.
It might be.
There is one back there. We have a question from the audience.
Did the patient receive
With
antibiotics?
such a big tumor, for example, we cannot go with the Procore needle, 19 gauge, and obtain better tissue biopsy for histopathology, especially that GIST is one of the differentials.
We
The
could
question is, why
we
not
could.
use a 19 gauge needle?
Procor.
I'm not sure the 19 gauge would be better, but the Procore would be an option. We can of course use a Procore. We had a 22 gauge ready, so I didn't ask a 19 gauge, but if the idea would be to have a biopsy, that would be probably an option. So we will use the Procore needle. My needle. Then I insert the needle in, and then we will make the pass by while removing the membrane.